Hello, I'm Dr. Jonathan Levine, host of Case Bites, where we unravel the complexities in dentistry from simple to complex cases from a treatment planning case presentation standpoint. Let's get started. Today, we have Dr. Stanislava Misci of Boston University, Goldman School of Dentistry in the Prosthodontic Faculty Department. So excited to have Dr. Stanislava here. She's an amazing prosthodontist, great part of our Case Bite team. Welcome, Dr. Stanislava Misci, for presenting to us. I know it's going to be a beautiful case, and we're really excited to weigh in. We have Dr. Alan Jerem, restorative dentist, Dr. Rick Robley, orthodontist from Fayetteville, Arkansas, and Dr. John Kim, coming from North Carolina. So we have all the specialties covered for our interdisciplinary conversation. Please take it away.
Thank you very much, Dr. Levine, for your kind introduction. I'm very honored to be here with everybody tonight and to be part of this team. And tonight I will share one of the cases we did at Boston University with one of our residents, Dr. Abdallah. Now, I will concentrate today a little bit on the edentulous arch and our treatment options. As we know, we have a number of options now in the world of implant dentistry that we can present to our patients. We have the removable options for the edentulous arch. We have the fixed restorations. We can have a screw retained. We can have cement retained. We can go to implant level. We can stay at abutment level. And we have the locator abutment type for the removable dentures. So in this world, we have so many options, and yet we have to be very careful how we evaluate the patient and which options are actually going to fit each case. This next case we treated at Boston University, and our team consisted of Dr. Abdallah, who was the resident on the case. He just graduated. He is a wonderful, very talented new prosthodontist and just joined the faculty list, so we're very proud to have him. I was the faculty on the case, and we had our surgical team, Doctors Bayoumi and Deng, and our oral and maxillofacial surgery faculty, Dr. Hussam Batal. Our patient presented with multiple missing upper teeth and was interested to restore his arch, to have more teeth, to be able to eat and smile, and he was looking for a clean, healthy, and natural type of look. Medically, the patient is very healthy, no contraindications for dental treatment. His panoramic radiograph shows partially edentulous maxilla and mandible. The first time he actually presented, he still had a maxillary anterior FPD, which he lost shortly after. So when we actually started treating the patient, that bridge was already gone. So we had to start from scratch our evaluations. But in any ways, our periodontal assessment was pretty fair. He had a few fours in the probing depths, nothing that concerning. He had some flaring of the lower anterior teeth and some rotation of the canines. We can look into that a little bit later. Aesthetic evaluation, patient presents showing no maxillary teeth shortly after this picture was taken. So at this point, he still had his anterior bridge, and he's looking for a clean, healthy, and natural smile. To continue with our analysis, our smile analysis shows intrapupillary line is parallel to the incisal line. Midline is coincidental with the midline of the face. Lips and face, on the right side, we can see his muscles retract the lip a little bit more than the left side. However, he has less teeth on that side, so it's possible just how the soft tissue fall in place. In terms of lips, pretty full lips, normal exposure, maybe a little bit on the deficiency. In terms of profile, within normal range. We can see his low smile line, at least on this picture. The teeth are not touching, the midlines are centered. He has a straight line between his anteriors, and in terms of midline, it's pretty straight as well. FNS sound pretty good. I do not concentrate too much on the sounds at this point, as whatever the patients usually present with, that is a result of a long-term standing, and the patients can adapt to making the sounds pretty clear. We all know even edentulous patients can say SNF pretty clearly. However, when we are restoring the patient and we're trying to find that new position, at that point is more critical to me. Now, in terms of size of the teeth and ratios, we can see that the bridge that he presented with was a long teeth. In terms of width, they were within the normal parameters. And on this slide, we can basically see that we can improve every parameter on that slide. We're proposing to decrease the length of the teeth on the maxilla and also give a little bit less gingival display. For the lower anteriors at that point, we determined that vertically the incisal edge is in a favorable, acceptable position. However, he had the flaring on the lower incisors, and we attempted some orthodontics through both conventional orthodontics with braces and Invisalign, and patient could not tolerate it. So we had to abort that option. In any case, we can see that the patient has no posterior support, so a lot of issues to address here. But just like with any other case, we like to have a few steps that are very critical. And for me, these are three. The first step is to determine the future tooth position, the tooth setup. Now, we all learned in dental school complete dentures, so we use the complete denture concept for every case, whether it is a case of fully dentated patients, and we will be doing 28 crowns, or a case where we have edentulous patients, we'll be restoring with complete dentures or overdentures or fixed complete dentures or partial dentures. We always want to determine what is our ideal design, our future tooth setup that we want to achieve. And it comes through evaluating and striving for a lot of parameters. We're looking at intrapupillary line, midline, lip support, gingival display, lip retraction. However, it really comes down to just a few positions, which if we determine, we can develop the rest of the occlusion and the rest of our setup. So it comes down to maxillary incisal edge position, just like we learned with dentures, determining the mandibular incisal edge positions. Then we have to decide at what vertical dimensions we will be restoring this case in order for the patient to have proper aesthetics and function. And we have to restore the case in some repeatable position, like a CR position. Now, for this particular patient, again, looking at the smile and the incisal display, we're looking to change slightly with the future restorations for the maxillary incisors. And the first step, as I said, he lost the bridge almost immediately after we saw him initially. We had to make some interim prostheses. We had to give the patient some immediate aesthetics and functions, so an interim maxillary complete denture was fabricated first. At that point, we evaluated the tooth positions, the phonetics, the aesthetics, all the parameters, and decided that we need to make a few changes on the tooth position. So again, back to our first point, the first step where we are trying to determine our future tooth setup. So we made those changes digitally. We scanned the denture, and Dr. Abdallah made the modifications of the tooth position through a software. And then we continue with the next steps. The second step in my world is usually the prosthetic flange for those cases. So I want to know for this particular patient, do we need a prosthetic flange or we don't need a prosthetic flange? And that's a big question mark. Most patients present to us want fixed restorations. They don't like the dentures. They don't want the dentures. But not every case can be case without a flange. So if we need a prosthetic flange, we'll have to go with the complete denture or over denture options. And if we don't need a prosthetic flange, we can go with the fixed restoration option. So based on that digitally modified tooth setup from that initial denture that was immediately fabricated for this patient, we made two files. One is the file that has the flange and one file on which we digitally remove the flange. Now, based on those, we do print two prototypes, one with the flange and one without the flange. Now, at our next appointment with the patient, we will be determining the need for a flange. So we insert first the prototype that has the flange, evaluate the patient. And in this case, we can see that the patient has pretty good aesthetics and lip support with the flange. And then we evaluate the prototype without the flange. So in this case, we can see that the patient can tolerate no flange. So at that point, that's a very pivotal point for our patients because we see a number of patients, especially female patients with more advanced bone loss on the maxilla. Of course, they come and they want to have a fixed restorative option. However, once presented with a prototype with no flange, they realize that that's not an option for them because we women like to have a little fullness on the lip. So now, as I am showing this case, I'm showing some digital steps, but back to what Dr. Levine was discussing earlier, we do not need to always utilize digital options if we don't have them available. They make our life very easy, but if we don't have them available, this could easily be just a duplicate of that initial denture, two duplicates, we cut the flange off on one and not on the other and proceed exactly the same steps. So now that we have determined that we have our teeth set up position and we can go without the flange for this particular patient, we go to our next step, which is the third step in my treatment planning, which is the position of the prosthetic margin. Now, the prosthetic margin is the margin between our restorative material and between our tissues, whether it's between a white restorative material and pink tissue, or it is between a pink restorative material and pink tissue. This is something we need to determine at that next stage. And also we need to determine exactly where that prosthetic margin is going to lay. In order to do that, we go back to the prototypes that we printed for our patient. And we use the prototype that actually has the flange. And at that point, we ask the patient to make different kind of movements, exaggerated smiling, laughing, talking, just to see how far his muscles can naturally retract the lips. And then we mark that line. We want to see worst case scenario, what the patient would be showing. So in my protocol, I like to mark that line and put some sort of a radio opaque marker on that line before we do the CT scan. So in this case, we marked above every tooth and put a gutta-percha marker. So now with our next step in the digital planning is to do the CT scan, which we do a double scan technique in which we first scan the denture by itself or the prototype by itself. And then the patient is wearing the prototype and scanning the patient with that prototype in place. What is the benefit on that is that now not only we have the data about the tooth position for our planning of the implants, but we also have the data for our lip position, most retracted lip position. And that data is available for every tooth for which we can place an implant. As I said earlier, I don't know at this point where my implants will go. We didn't have the CT scan yet. However, now I have all the information. We can evaluate the different sites. We can see how we want to spread out those implants, what angulation they will go, and then determine how would they position in relationship to the teeth, but also how would they position in relationship to that retracted lip position. We have had for many years all the big names in dentistry tell us and teach us about how we need to hide that prosthetic margin to be away from any visible area on our smile. However, now with the digital technology, we can easily transfer that information to our planning. So those white dots, as I said, this is our retracted lip position, and I usually like to stay for my implant platform about 5 millimeters from that retracted lip position. And the reason is 2 to 3 millimeters for the soft tissue above the implant, and then another 2 millimeters for that restorative material, the pink material, just to give us a little bit of a cushion in terms of patient showing any margins at any point. So now that we have that information on a CT scan, we can plan our implant depth, which is a very important part of implant planning. Even though if we don't have this information, we could have placed probably our implants to the level of the existing bone. But as we can see, that would be too superficial, and then it would show when the patient is smiling and functioning, that prosthetic margin would show. So that protocol is something we use now routinely, as that is very valuable information giving us for the surgery. From there on, the case is very straightforward. Based on that digital planning, we have a surgical guide fabricated. At the day of surgery, that denture is converted into a fixed restoration. The implants are placed, multi-unit abutments are used, and we have the immediate restoration placed. Now, as I said, the 3 pivotal steps in this planning approach is to determine the position of the teeth, to determine the need of prosthetic flange, and to determine the position of the prosthetic margin. These are my 3 go-to. Now that the patient has healed, we made some modifications to the provisionals. Dr. Abdallah provisionalized the lowers as well. And at that point, we are ready to go. We basically scanned that provisional, full contour, and did some digital cutback. If we decide we don't have to necessarily do a cutback for the teeth, we just can do cutback or staining of the pink area. And then the frame is milled, veneered in this case, and delivered. This is all from me. I want to thank everybody very much for this opportunity to share some of my work and experience and some of the work of our residents, and to thank everybody for the opportunity to be here. And hopefully we can discuss now and learn from each other.
Thank you, Dr. Misci. I'm what resonates for me to think about this is the word predictability. Using digital dentistry, using some analog, but really the fundamentals of what we know. You're determining through those 3 data points that you've so beautifully described, the flange and the end of the margin. And these data points are so critical as it relates to high smile line, what's showing, and really the naturalness and the support of the lip is so well developed by the neutral zone from Pound's work. If we go back to the dentures in the 60s, talk about fundamentals. But it's a great workflow, and using our CBCT and our 3D imaging. Thank you for that. It's so amazing how fast everything is evolving in digital dentistry. Let me bring it out to the group with some of our digital experts there. Take it away.
The case was very beautiful, and one of the things I liked, which I've seen, is aligning in your surgical plan all that different information where you can see the planned position of the implant, you can see the aligned position of the exaggerated smile line, through the markers that you put into the scan. You can see the multi-unit abutment that was proposed and the type of angulation. So looking into the future with the digital planning it's providing such a great service to understand the surgery and the prosthetics before bringing it to the patient. So as we were saying in the other case, the ability to test and prosthodontics to be able to try it's another tool within digital to see what prosthetics are going to be available, maybe used for the case before in that planning phase. And it allows for a much easier workflow when you're coming down to the point of giving this patient back teeth and maintaining that predictable tooth position that you established earlier on. So it's really great to see the alignment of all the different data and how that really helps with the end in mind, the end of the treatment.
I think that was a beautiful case you shared, Dr. Misci, and I honestly haven't probably incorporated enough digital workflow into implant dentistry, but I do find it particularly beneficial for these type of cases here. When you have, like, for example, a fully edentulous case, and if you could have a surgical guide created with proper planning with your fellow team members, as a surgeon, it's always nice to be able to know the exact location and the angle and also the proper depth of the implant to make sure that the procedure goes as well as it should. And when you have a fully edentulous case, you don't have an adjacent tooth as a reference. I mean, it's just so much helpful. And I found that following the digital workflow has really helped me out in these full arch reconstruction cases here. And you showed why it does that with this beautiful case.
Everything is much more predictable. It comes down to measurements. But again, it is the fundamentals that we have to understand, and then the digital workflow makes it so much easier and smoother.
The idea of measurements, there are certain things that you can do in digital dentistry that's more difficult to do in analog dentistry, and it's really those measurements. It's comparing data, and having the ability to take those measurements digitally it gives you more insight into the case, and that's what I really think is beneficial to digital dentistry in certain scenarios, is the alignment of the data, which then allows you to take measurements and then infer from that and influence your decision-making process based off that. It's really great to see how it comes together.
The numbers are important. The numbers don't lie.
It creates that systematic approach to how do you solve a case like this. And the numbers are what you need to feed into the system in order to get the right output as to what direction you should take the case in. And it will never lie if you can get the numbers and you can get the measurements properly.
Beautiful case, beautiful use of technology again. And I love this. Obviously, I'm not doing too much prosthetics at this level because I move teeth and jaw structures, but this is absolutely gorgeous. And this was the genesis, of how you're applying it to your prosthetics, to what we do to the natural dentition and the natural structures. So I think this is a beautiful example of marrying classic removable prosthodontics with the state-of-the-art digital technology. And so beautiful work.
That's it. Analog meets digital for precision and predictability. That could be a title. It's really exciting to understand this workflow, but we're going to go back to it. So many times when we're talking together, we all keep talking about the fundamentals, and isn't that the truth? But this digital workflow, once the fundamentals are established, it is really exciting. I love the dress rehearsal. I love the testing, because at the end of the day, you took the big question marks out of the equation. Do we put the flange? Do we not put the flange? So this all on 4 or all on 5 or all on 6, depending on how many implants you have. What's that prosthesis is it going to look like? What's that? How big is that pink zone going to be? What's the length of the tooth going to be that you established early on? So all of this preparation really takes the guesswork. And then the digital side, as everybody's talking about, brings those numbers for implant position and placement, all that precision that's coming off the 3D planning as it relates to where do I want that tooth. Pretty amazing. So we're getting better. Digital workflow is really making us better and better. It's very exciting about our profession. Well, that wraps it. That wraps it for Case Bites. One more great session from everybody. Thank you, everybody. Stanislava, Rick Robley, Alan Durham, John, Kim, Rocky Mount, North Carolina. John, you are single-handedly going to put that town on the map. Sitting right outside of Raleigh. They're going to go Rocky Mount. Yep, Dr. John Kim, periodontist. Superb. Unbelievable group. You guys are so much fun. We're doing it again soon. See y'all later.
Thank you.
Thank you for joining us for Case Bites. If you haven't already, please subscribe to this series to receive a new case in your inbox every week.